Good morning, everybody. Welcome to this morning's webinar. I'm Councillor Chris Kennedy. I'm the Cabinet Member for Health at the London Borough of Hackney, and I also co-chair the London Smoke-Free Councillors Network. About 200 of you have registered for the session today. I see we're almost up into treble figures. Thank you so much. Look, smoking is still the biggest cause of preventable death in our country. And still a huge driver of health inequality. I think the thing that struck me most, and I think the thing that moved the dial most, was when Chris Whitty kept reminding us that more people died of smoking-related causes than died of COVID in the worst year of COVID. It felt like that was a huge shift and a huge moment when everyone just went, this is completely unacceptable. Let's do something about it. Politicians of all parties came together, and the Tobacco and Vapes Bill, hurrah, is going fairly quickly and fairly well and fairly smoothly through Parliament. It's absolutely fabulous. At the same time of that, of course, we got a 10-year NHS health plan talking of the move to prevention from treatment, and at local authority level, both at officer level and at political level, we'd been saying for ages that on smoking and tobacco, we could really move towards a lot more prevention, so that there weren't people needing to be treated for smoking related diseases. If you gave us the money, and we could do that with the third sector and with NHS partners, if only we had the money. Now we've got the money, and it's ring-fenced for 3 years. So that makes this morning's webinar my favourite kind of webinar, which is listening to brilliant ideas about how to spend funding that you know you've already got coming through, and you have got for another 3 years, that you know will really change the dial on health inequality. So I'm absolutely delighted to be introducing this packed agenda of brilliant speakers. So as you can see, loads of great stuff to come, loads of ideas coming your way. The presentations will include an overview of the current state of play in tobacco control. We'll have a look through some of the evidence on the most effective ways to boost those quit numbers, case studies from different areas, all sorts of innovation about how you can best spend that money that you know you've got coming in your area. Quick bit of housekeeping. So of course the meeting will be recorded, is being recorded, and it'll be uploaded to the ASH website and shared with all attendees and everyone who registered, along with the slides, of course. Quick reminder to panelists and attendees, please keep yourselves muted, turn off your videos unless you're presenting, and ASH staff will mute anyone who is unmuted whilst they're not presenting. So that should be done for you, but just keep an eye on it yourself. Please do submit questions, reflections in the meeting chat. We've got a Q&A session at the end that I hope we'll still have enough time for. And the speakers themselves will be monitoring the chat. Hopefully we'll be able to answer some of the questions as we go along. If you've got any other issues, just pop that in the meeting chat, or you can email admin@smokefreeaction.org.uk. If you are having technical issues, just check your meeting settings, make sure you've got your right audio microphone selected as you're either leaving or rejoining. So bang on time, 11:05. Our first brilliant speaker is John Waldron, Director of Public Policy and Public Affairs at ASH. John, over to you.
Thank you very much, Chris. Hi, everyone. Good to see so many people in attendance today. I'm just going to give a very quick whistle-stop tour through the findings of our latest survey of local tobacco controls. So next slide, please. So a bit of background about the survey, which I'm sure most of you are aware of. This is the 12th annual survey of tobacco control, and that covers things like a whole range of tobacco control activities, so investment, demand for services, kind of interventions people are delivering locally, and level of priority for tobacco versus other areas. So it's a really comprehensive series of reports, And we carried out the survey between August and September last year, and we had 84% of local authorities with responsibilities for public health responding. And the report is available to view online if anyone's interested. And the key headline coming out of that was that this new government investment in stop smoking services has delivered expanded services that are working hard to reach smokers in all communities and reduce health inequalities as a key priority. And we called the report Breaking New Ground because one of the key kind of striking things coming out of the findings was the extent to which stop smoking services were really reaching out into new settings, new communities to reach smokers where they are rather than expecting them to come to us, which I think is absolutely crucial for achieving an equitable progress to a smoke-free society. Next slide, please. So they're the key findings. I'm just going to run through these very, very briefly. So next slide. Just starting off, one of the key finding really was that tobacco control was ranked as a higher priority for local authorities than ever before in the 12 years we've been running the survey. So you can see the change from 2021 to 2025 there. And you can see in 2021, around 40% of respondents saying that tobacco control was above average or high priority. And then by 2025, around 90% saying, which is a real transformation. And you can see a real jump between 23 and 24. And that has really been driven by the announcement of that new stop smoking service funding, which obviously plays a really key role in allowing services to expand their capacity and their reach, but then also the announcement of the Tobacco and Vapes Bill at the end of 2023, and then that's been kind of going through this very drawn-out legislative process since then, which really helped to put smoking and tobacco control back on the agenda nationally, locally, and stop smoking services and councils and councillors and directors of public health and tobacco control leads have all really come together to champion this legislation and to really seize the opportunity of this idea of creating a smoke-free society. And obviously councils have a critical role in delivering that. So next slide, please. The other thing we found was a big expansion of the capacity of stop smoking services. So we found that all local authorities now commission or provide stop smoking services, with over 80% increasing their advisor capacity, and many services doubling the number of advisors, which obviously really expands their reach. And alongside this, we found a massive increase in demand for services in over 80% of local authorities. And respondents said this was driven by a range of factors. So obviously comms campaigns playing a crucial role in driving people towards services, but community outreach, increased capacity, stronger referral pathways, and particularly from NHS tobacco treatment services, the swap to stop offer and the availability of vapes, which I'll come on to in a minute, and other kind of medications and treatment options, and then an expansion of training and very brief advice as well. So a real transformation in what services are able to deliver. So next slide. And we also found that targeting health inequalities and disadvantaged groups was a real priority for local authorities, and local authorities were really expanding their reach into different services and different communities. So the number of settings where stop smoking services were provided increased in over 80% of local authorities, and I've included a few quotes there. There's a lot more, there's some really rich quotes and qualitative data in the report, so I do recommend people go have a read. But some of the settings people cited were things like community centres, family hubs, a range of kind of routine and manual workplaces, drug and alcohol services, social housing, food banks, settings for asylum seekers and homeless people. So really prioritising the groups with the highest disadvantage, the biggest challenges with accessing traditional services, and obviously the highest smoking rates as well. Next slide, please. We also found a big expansion in the kind of treatment offer available for people, although there is still somewhere to go. So you can see there that the number of services offering varenicline and cytosine has really expanded over the last between 2024 and 2025, with 70% of services offering varenicline. Obviously, these are highly effective stop smoking medications. They're NICE recommended. So I think for the 2026 survey, I really want to see as close to 100% of services as we can get, offering these evidence-based medications. Alongside this, we found that virtually all stop smoking services were offering people vapes, and similarly virtually all services were participating in the national Swap to Stop program, offering people free vapes and stop smoking support. And the benefits from the Swap to Stop program that were cited by participants included increased quit attempts and quit rates, which is key, better choice for service users in the range of stop smoking as they have. It was also really popular with service users, which I think is critical. You didn't have to persuade them very much that these products were helpful, and it was particularly useful for engaging people from some of the most disadvantaged backgrounds. Vapes are also a good alternative for people who didn't want to access traditional stop smoking support or other treatments and medications maybe that they tried before and didn't like. It's obviously zero cost, which is great for service users, and vapes are very simple to deliver compared to some of the other medications as well. Next slide, please. So looking at integration with NHS services, you can see there from the graph, there has been a lot of integration between community stop smoking services and NHS services. So around half of stop smoking services would say they're substantially or fully integrated with NHS tobacco treatment services, and around 40% saying that about NHS lung health checks. So some really good progress, but still quite a ways to go with building those links and building that kind of comprehensive system-wide approach. That means that whichever services smokers access, whether it's the NHS, whether it's community, whether it's kind of third sector, other support, that they are provided with a kind of comprehensive stop smoking support and aren't falling through the cracks. And one of the things people did flag is that integration has been limited by the financial uncertainty affecting tobacco treatment services in the NHS. I think given that isn't likely to disappear anytime soon, the question is how can local government and stop smoking services kind of work around that to ensure that smokers, those referral pathways do exist and that expertise can be shared and that people aren't falling through the cracks, as I said. So next slide, please. And then finally, just looking at investment in wider tobacco control. Obviously, the focus today is stop smoking services, but the wider tobacco control picture is obviously really important as well. So as you would expect, local authorities are investing in wider tobacco control work, so illicit tobacco and vape enforcement, public communications campaigns, really key for driving people to services and for triggering quit attempts, and also work to promote smoke-free homes alongside several other areas as well. And I included just a couple of examples from the quotes. So one from the East Riding of Yorkshire, where they were running a smoke-free homes reward schemes for pregnant smokers and household members. And then in South East London, where they were running a public comms campaign to promote the smoke-free app and local stop smoking services, which I know has had really good take-up as well. So a couple of great examples, and there's a lot more in the report. And then next slide. And just to finish on a kind of encouraging quote, and if anyone wants to feel uplifted, I would go and read the report because there are so many positive quotes in there. But this one's from Birmingham, and it just really sums up the key points, I think. So thanks to the additional funding, we've been able to expand our stop smoking support into a wider range of settings. This means integrating with existing drug and alcohol services, provision of support in mental health settings, both inpatient and the community, and increased outreach in the wider community. And these developments have let us reach more individuals in need of support, particularly those in vulnerable or underserved groups. And so I think I'll finish it there. Thank you very much.
John, that was brilliant. Thank you, and bang on time. Absolutely lovely to hear that very, very clear news that it's a higher priority than ever now for local authorities, and that the advent of the bill and the funding means that is absolutely there. Our next brilliant speaker to give us an update on the new smoking cessation funding setup, just to explain how it all works, from the Department of Health and Social Care, Head of Smoking Cessation, Gemma Kane. Gemma. You're on mute, Gemma.
Oh, there we go. Can you hear me now?
Yes.
Perfect. Great. And also feeling, the pressure to keep on time because everyone has done so well. so far. So thank you. As Chris said, I'm Gemma Kane and I head up our team leading on smoking cessation in the Department of Health and Social Care, which has previously included the local stop smoking services and support grant, but now includes the sort of consolidated smoking funding within the public health grant. And the plan today is just to run through sort of what changes are taking place, what this means in practice, and how we can work together to make the most of the new funding. Because as Chris set out at the beginning, I think we've reached a really positive outcome for smoking, and it's great to have the funding protected and also to have that certainty over the next few years as well. So if we could just go on to the next slide. So I think it's important to set out the context in which this has sort of come about, which I'm sure many of you are familiar with. But there's been a lot of changes to local government funding from April this year, so the new financial year. And the Ministry of Housing, Communities and Local Government have had a large programme of work across government to simplify local government funding. And they've been trying to consolidate grants and remove ring fences where possible, all with the aim of giving local authorities more flexibility over how they spend their funding, because we know that they'll know what suits the needs of their local population. And there's also been a big push to provide multi-year funding allocations to provide greater certainty over how much money local authorities will have so they can better plan their services in the longer term, which we know is really beneficial. So what they've done is they've consolidated a huge number of grants across all government spending going to local authorities into the local government finance settlement. And last month they published the allocations for this over the next 3 years up until 2028-29. So it's really positive to have funding sort of set out for the full SR period over that time. And public health is obviously a huge amount of funding within that. So the public health grant will remain ring fenced for public health, which we know is really positive for protecting investment in these vital services. So we go on to the next slide. I'll just set out a bit what this means for smoking cessation funding, because it has some important implications for that. But as I said at the beginning, I think we've reached a really positive outcome. So in terms of trying to simplify and streamline our funding, what we've done is we've brought together 3 different areas that I've set out here. So the first is the sort of existing spend within the public health grant. So for those of you that have been working with the additional grant that we've given, you know that we went through an exercise before we launched the grant to figure out how much money each local authority was spending within their public health grant on stop smoking services, which in total represents about £64 million. Secondly, we've obviously got our, over the last couple of years, had our additional £70 million funding. And then thirdly, we had the Swap to Stop scheme, which I know loads of you have been involved in and it's been really positive, which represents about £17 million. And I know that wasn't a grant, but that was programme funding that local authorities and other organisations could bid for. So what we've done is we've basically consolidated all of this money into one pot, which represents just over £150 million per year. And we've ring fenced that in total for stop smoking services. And the way we've done this is trying to balance protecting sort of historic spend where local authorities have really positively invested in their stop smoking services, but also balance it against need. So sort of point 1 on this slide is sort of historic spend, and then points 2 and 3 in the new setup are distributed based on smoking prevalence. So that is more needs-based. But we know that it's really important to protect this funding for stop smoking services. So this total pot will be ring fenced within the public health grant just to be spent on helping smokers to quit, which is, as I say, a really positive outcome because we know that it's really important to protect that. It's important just to note that this doesn't include the wider tobacco control spend. So you'll know that when you're reporting against your public health spending, they're 2 sort of separate reporting mechanisms. And the sort of broader tobacco control funding wasn't, when we looked back at what was spent within the public health grant, that wasn't consolidated into this £153 million. So that sort of sits slightly outside of this funding. So we move on to the next slide. So alongside the public health grant conditions, which we now sit within, there are 3 smoking specific conditions, which broadly mirror what was in the stop smoking services and support grant, the additional 70 million. But we've added 1 additional condition as well, which I think is a really positive addition. So I'll just run through them quickly. So the first one is about what you can spend the funding on. So this means that you must be spent on supporting smokers to quit. So as I say, it can't be spent on anything else, and also particularly can't be spent on wider tobacco control because that sits slightly separately. And also can't be used to replace existing NHS tobacco dependency services in inpatient and maternity settings. Couple of points to note that it's important. This is the minimum amount to be spent. This is a floor rather than a ceiling. So if local authorities chose to, they could invest more money from their public health grant on smoking cessation, but this is sort of the minimum amount that must be spent. And then just particularly wanted to draw out on the NHS point. This is about preventing the funding being used to sort of backfill NHS opt-out tobacco dependency services that should exist and be funded through ICBs, but this doesn't preclude partnership working with the NHS because we know that sort of outreach with NHS services can be really beneficial. Secondly, on the sort of reporting and what we expect to deliver. So this is sort of pretty much identical to what was in the additional grant money. So we're expecting people to increase the number of people setting a quit date, increase the number of 4-week quits, and then to report that activity back to us as people have been doing previously as well. And then thirdly is the new one. So this is what we've introduced, a condition that for any local authorities reaching less than 5% of their smoking population setting quit dates, they must submit a self-assessment audit within the end of the financial year. Early in April, we will be publishing some further guidance about what the tool looks like, what that means, the process for all of that. But just to say that we're intending this to be a sort of really helpful, positive tool for helping people look at their stop smoking services and how they can improve them. So it's there to sort of help you have those conversations and drive improvement rather than a sort of top-down thing to impose on people, really hoping that it will be useful to everybody. And on that note, it's important to say that whilst it will be mandatory for those not reaching the 5% threshold, we'd really encourage all local authorities to complete and submit it and have those conversations, because as I said, it should be a really useful tool. And then if we just go on to the next slide, so just talking a bit about what this means in practice for local authorities. So there's a few really positive things. So it means that you'll have greater certainty of your funding. As we said at the beginning, we've got 3 years of allocations, so we know that people can invest in those services with confidence, which is really important. For most local authorities, the amount of funding they receive will, in terms of a dedicated grant, will have gone up because, as I said, we've added in the swap to stop funding, which will go to all local authorities. You won't need to bid for that. You'll just get the money distributed based on smoking prevalence. So you know that you've got that with certainty, and that will sort of increase your total ring fence pot for stop smoking services. Thirdly, you'll have a bit more flexibility how you spend the money. So as I said, with swap to stop, you don't necessarily have to spend that on vape. So you can definitely choose to if that sort of suits the needs of your local population, but you will just get the sort of total pot of money there to decide how you best like to spend that on your local population. And finally, through the sort of development of our self-assessment improvement tool, which I just mentioned in the last slide, this will provide additional support for service improvement and another mechanism in which you can sort of review your stop smoking services and think about how you can improve that. In terms of next steps, we're just basically working to sort of finalise and close down the previous grant scheme and make sure that the new payments are issued via the public health grant in April. We'll launch the new audit tool early in the financial year as well, so that people have that and can get used to that tool. And then also just working through how we make sure that we're really streamlined with the wider public health grant assurance processes. And then just quickly on the final slide, so just to sort of touch quickly on our Ask Give You, I think the first one is just keep using partnerships, whether that's with the NHS, whether it's with other settings, whether it's with other local areas across a sort of broader geographical area, like keep working together, because we know that really provides really positive services. The second is just continue to focus on the areas and sort of priority groups that need the most support. So we know as smoking prevalence comes down, it'll be really important to reach those different groups. Thirdly is making sure that we have the full range of quit aids available. We know that what works is best for people is different for everybody. So trying to explore the full use of those tools, whether that's NRT, vapes, stop smoking medications, etc. Please use once it's launched, the self-assessment and improvement tool. We think that will be really positive to help drive service improvement. And then finally, just to say that this is obviously a new setup. We're still learning about like how this will work, what the barriers might be. So please do provide feedback on what's working. If there's things that we can do that will be more helpful, then please do let us know. And I think that's everything from me, and hopefully on time as well.
Gemma, right on time. Brilliant. Thank you so much. There's a few questions for you in the chat. If you've got time to stay, please, and maybe pick up some of those. There's some great links in the chat that Hazel and John have been popping in there about webinars, further details of stuff that's being presented. But I'm absolutely delighted now to introduce the boss of ASH, the chief exec, Hazel Cheeseman, who's going to talk to us about this new funding and ideas about how to use it. Hazel, over to you. Thank you.
Brilliant, thanks, Chris, and thanks to Gemma and John as well. So I'm gonna some of what I say might be sort of affirming some of the things that Gemma has said, but I think my task here is really to put this spending, this funding in that broader strategic context of what it is we're trying to achieve as a tobacco control community. So if we move on to my next slide. I think it's really important as we are thinking about this new investment to take a little step back and think about this moment in time. We have this transformative piece of legislation which is very, very close to becoming law, which I think really does shift our narrative and our approach and the way that we should be thinking about reducing smoking across the country. The generational smoking ban kind of sets this idea, not that we are a question of sort of if we will end smoking, but rather a question of when we will end smoking. And I think the job of all of us out in our local authorities and the NHS services and in the other organisations that we're in is about how we can get there as quickly as possible and as equitably as possible. We've also got we're going to have new powers around regulating tobacco and nicotine products, which provide new opportunities. And of course, the investment not only in the local government smoking cessation services, but in that broader enforcement activity and the wider activity in the NHS. So it's a really unprecedented opportunity to think about how we're going to get there for every community. And I think it is a bigger question just than sort of how we commission our stop smoking services. So if I move on to my next slide. So Ash has hopefully somebody will put a link to this in the chat as we're talking, or certainly it will go around afterwards. We have produced a new briefing and I'm going to sort of talk through the headlines of this, and then the speakers that will follow are going to kind of provide a little bit more life to some of these recommendations as well. So it's got 5 key areas of recommendation and I'm just going to kind of canter through that in the next few minutes. On my next slide is these 5 key areas of focus that we set out in the briefing. So it's about developing an ambitious strategy, prioritising health inequalities, obviously providing evidence-based quit support, but not just thinking about how we support people, but also how we motivate those quit attempts and how we work across our systems. So I'm going to just very briefly, talk about this in a little more detail. So next slide, thanks, Noah. So on developing an ambitious strategy, this is, as I say, it's a transformative moment. It's a great time to revisit the strategies that we already have or put one in place if we don't have them. And making sure that we're thinking not just about the services that we provide, but how are we going to increase quit attempts across our population and make sure that those are as successful as possible. And I know that others are going to talk more about that in the next presentations. How we're involving all our local partners, and then the value of having these targets that we own locally, that are not just these broad prevalence ambitious aspirations, but also thinking about our different communities that we particularly want to reach, because they give us the accountability to make sure that we are achieving the things that we want to achieve. On my next slide, I've just got a couple of pictures to sort of illustrate what people have done locally. So this is an old one from the Oxfordshire Tobacco Control Alliance, who I think are in the process of updating or may have already updated their strategy. And I love this framing around, like, you know, the final push, you know, this great kind of framing. And then here from Herefordshire, this overarching vision of, you know, we're going to get to 5% by 2030, and then the different strands that will support that. So there are obviously lots of different ways of doing this. There are loads of examples out there. I would urge you to go and see what colleagues are doing, but also, you know, it's a great chart. It's a great opportunity to reframe your ambition locally. Next slide. Health inequalities are an absolute golden thread that need to run through everything that we're doing. You know, it's not, you know, you will all know all the figures around smoking being the leading cause of health inequalities and you know, the prevalence in those communities that we want to reach most. And I think it's absolutely vital that as we are thinking about how we're going to use that resource, that we particularly think about how we're going to invest into those disadvantaged populations, which might need a bit more resource, might be a little bit harder to achieve those quit attempts and those quit successes, but are so important. And that's just an example here from Southwark, who've set out their priority groups and their strategy. So on my next slide, I'm going to talk now, and this will reaffirm again some of the stuff which Gemma has said about evidence-based quit support. So next slide, Noah. I think one of the things when we're thinking about how we're going to support our population to quit, it is important to be a little bit humble about the role of our services. They are so important, and they're really particularly important in terms of addressing health inequalities and making sure we can equalise the chances of quit success across populations. But even when we are absolutely going, you know, at maximum capacity, you know, we are still reaching a fairly small group in the population. So that, you know, the top two groups there are accessing behavioural support, and then we've only got sort of just over 3% who are accessing this, you know, the absolute kind of gold standard behavioural support and medication. And then lots of other people, you know, we're using different ways of quitting smoking, and obviously e-cigarettes remain the most popular way of quitting smoking. We've got this big chunk of people that are not doing anything. So what do we do to think about them? And then if we go back to the beginning, only 1 in 3 smokers have tried to stop smoking in 2025. And if they don't try, then they can't succeed. So how are we going to get more people to give it a go? So on my next slide. And again, this affirms some of the stuff that we just know. Like, you know, obviously this funding should make sure that we are delivering evidence-based, nice recommended support to all the smokers that we can. And there's been a really like productive chat about varenicline in the chat, and you know, obviously increasing access to some of these very effective tools is really important. The Swap to Stop scheme has been a really important tool for getting people to use something that's going to increase their chances of successfully quitting. Very high participation from councils up till now. Obviously the way that that's being funded is changing, but it shouldn't change the fact that we need to still deploy that resource to provide access to vapes for those that need it. As we're expanding our workforce, we obviously need to make sure that the quality of that workforce is retained, and obviously we have this fabulous resources through the NCSCT. But also I think, as I say, we need to think as well as the people coming through our services, how for our whole population are we going to be thinking about getting everyone to use a more effective way of quitting than nothing at all. So what are we doing to address the misperceptions around risk from vaping? What are we doing to make sure that the Swap to Stop scheme isn't just through our local government services, but also in those other settings where it might reach more people? And what about other tools that might, for people that are not going to access a traditional stop smoking service, are there other ways of expanding reach through sort of evidence-based apps, text messaging, etc., etc.? And then if I move on to my next slide, crucial in thinking about how we're going to get to our smoke-free future as quickly as possible for as many people as possible is thinking about what we can do to really drive those quit attempts. And I know that the other speakers are going to speak more to this as well, but obviously that is about that those communication channels, thinking about the ways in which we can reach out at regional and local level to really amplify the case for quitting, right now. And plainly, the introduction of the smoke-free generation, this phasing out of the sale of tobacco, is a key kind of communication moment where we could get lots of people engaged in participating and being part of the smoke-free generation. And then
1 minute, Hazel.
Oh gosh, right. Next slide then. And working in partnership across our and I don't think I need to go into this a lot of detail because I know that other speakers are going to more. So I think my final slide just probably wraps that all up, I hope. Oh right, no, links and resources. So what we've got, the briefing that will be coming out, there are other things that are going in the chat and I think when we put this up online, we'll make sure that we include those links as well for those who are watching this back. But there's loads and loads of tools on the ASH website, some of which have been developed with Fresh and others who are speaking. I would urge you to access those, and obviously all the tools and resources through places like NCSCT as well. So I will stop there and hand over to our other speakers who are going to kind of add colour, I think, to some of this.
Brilliant. Thank you so much, Hazel. Yes, so number 4 on your list, increased quit attempts. And our next speaker, who's going to look for us at the sort of like evidence update on how local services can boost those quit attempts, is our Senior Research Fellow from UCL, Dr. Loren Kock. Loren, over to you.
Great, thanks very much. So just to start, I'm going to be presenting data from the Smoking Toolkit study, which is, for those of you who aren't familiar, it's a nationally representative cross-sectional survey of smoking and nicotine use in England. Next slide. Just to state my declarations. Next slide. So today I'll be first giving an overview of some interesting emerging patterns in tobacco and nicotine use that I think provides some really important and interesting context for the work that you're going to be delivering over the next few years. And then I'll focus a bit more on the evidence base around boosting smoking quit attempts and success. And there's a lot of overlap with other speakers, but hopefully it'll give some helpful data and evidence to work with. Next slide. So firstly, I'll be focusing on some emerging patterns. Next slide. So most of you will be familiar with this kind of broad annual trend graph showing the decline in smoking prevalence over recent decades. There are 2 key points I wanted to draw out here. If we look at just daily smoking prevalence, which is shown by this blue line, which is the lower line, we've seen there's a very consistent decline over time over the last few decades. And as of the most recent data collected, we'll have about 10 or 11% of people are smoking daily. But if we have a slightly looser measure, which is what we include in the Smoking Toolkit study, where we ask, what we define currently smoking as people that are smoking daily, but also non-daily, what you see in this purple line is a slightly less rosy picture, a slightly higher smoking prevalence. And what you might notice is that in the 2020s, you could argue that the decline in smoking is slowed and maybe stalled a little bit. And I raise this point just to say that there's been great progress so far with lots of policies and interventions, many of which you've been delivering and Ash has been pushing, but more work is needed to keep driving smoking prevalence down. And it's fantastic that it looks like the smoke-free generation policy will be stopping the inflow of new people smoking. But for existing smokers, more support is needed to really drive down this smoking rate. Next slide. And again, just very briefly, again, fantastic progress in reducing inequalities between smokers of different socioeconomic groups, but still persistent inequalities are seen with the rates of smoking in the least advantaged social grades around 3 times higher than the most advantaged. So those people are bearing the burden of ill health, suffering and mortality caused by smoking. So it's just to reiterate that more is needed to keep narrowing these inequalities. Next slide. Now, I raised this point about non-daily smoking in my opening slide, and it's an interesting thing to talk about, and it's something we've noticed has been increasing in the most recent years. So since 2018, 2019, we've seen this increasing proportion of smokers that are smoking non-daily. And as of the most recent published data here, it was around, well, a little over a quarter of people who smoke are doing so non-daily. And why is that relevant? Well, if people who are smoking non-daily have slightly different characteristics in terms of their ability to quit smoking or motivation to quit smoking, that's important to know, and it can help us focus resources and evidence to support quitting in different ways. Next slide. So one thing to think about, and one thing that we've looked at, has been motivation to stop smoking. And as I said, there's an increasing proportion of people who smoke that are doing so non-daily. And it also looks like, on average, they are more motivated to stop smoking than people who smoke daily. And this is an important point to think about. If that proportion is increasing and they're more motivated to stop, it's an opportunity to capitalize on that and really push them through that smoking cessation pathway, and take advantage of this emerging trend. At the same time, I really want to emphasize that the majority of people who smoke are still doing so daily. And within that group, certain subgroups, like those who've been smoking a long time, older people who smoke, those from less advantaged subgroups, are less motivated to quit. So yes, it's important to capitalize on this growing motivational group, but to remain focused on helping those who are less motivated and face more disadvantages that might prevent them from quitting. Next slide. I've got one slide just looking at nicotine use in general. I think it's a really interesting thing to think about. There have been some pretty stark generational shifts in nicotine use. So the top two panels in this figure are showing different types of nicotine product use and overall nicotine use in the youngest age groups. And what hopefully should be quite clear is that overall nicotine use has actually increased in the youngest age groups. That's largely driven by vaping and to a much lesser extent nicotine pouch use in recent years, but overall nicotine use has increased. Smoking has decreased, which is good, and that implies that there isn't this gateway from vaping to smoking, because if that was happening, you would see an increase in smoking. So ecologically, at that population level, we're not seeing that, which is really, really important. The majority of the non-daily smoking that we're seeing is among these younger groups. And then when we look at older adults, they're the ones that are mainly smoking daily, but there is some movement towards non-daily smoking in this group. But as you can see, as you look down towards the bottom of the figure, that the patterns are much less dramatic and they're much more stable. Next slide. And I touched on nicotine pouch use in the context of quitting smoking. I think it's a really important thing to keep monitoring and looking at in your local area. Are people using oral nicotine pouches to try and quit smoking? We are seeing at the population level increased use of nicotine pouches. On the face of it, we think that's probably a good thing. They deliver nicotine effectively. They might help reduce cravings and withdrawal for people who are trying to quit smoking, and they might increase quit attempts. The evidence base is quite thin at the moment, but our prior would be that they might be effective to help people quit smoking. So just something to keep in mind. Next slide, please. So I'll spend the rest of my presentation talking about some evidence around boosting quit attempts and quit success. Next slide. So a helpful place to start when thinking about this is, in England, what is motivating people to try and quit smoking? Now, for decades, really, future health concerns have been the most commonly cited reason that people say that they're trying to quit for. Interestingly, when mass media campaigns that were communicating the benefits of quitting and the harms of continued smoking, when those campaigns were frozen between 2011 and 2013, what hopefully should be quite clear here is there was this drop off in people citing future health concerns as a reason for quitting smoking. So that should hopefully illustrate that it's important to keep that messaging going, to keep it at the front of people's minds and to make a really salient reason for people to try and quit smoking. Another one, which again you might have noticed at the local level, is people citing that smoking is really expensive, and that's an important reason that they're trying to quit smoking. This is in the context of consistent tax rises over recent years that to some extent might be being passed to the people who are smoking by cigarette companies, but also during cost of living crisis, it is an expensive thing to do. So people are citing that as an important motivation. So hopefully just some helpful context to keep in mind. Next slide. I think it's helpful to think about the kind of dynamics of moving from being a smoker to being a quit attempter to managing to successfully quit. And this is a pretty simple dynamic, but the point I want to make here is that it's inherently unstable. It's a very difficult thing to do to quit smoking. People will make many quit attempts before they succeed. Some of you might have formerly smoked or currently smoke, maybe, so you'll know this. And it depends on a few different things. It depends on how long people have been smoking for, how dependent they are, what their motivation to stop is. Really importantly, if people manage to make a quit attempt, the type of method they use to quit smoking is really important about keeping them in that quit attempt, extending it to a point where they have successfully quit and they're much less likely to return to smoking. And being able to deal with urges to smoke, which will continue beyond the alleviation of withdrawal symptoms that people will feel in the more immediate period of quitting smoking. And behavioral support can really help train people to deal with those urges to smoke in the longer term. So it's really important to think about the different methods we use that we promote for people to quit smoking. Next slide. So quitting smoking is very difficult. It's a very unstable kind of dynamic. I wanted to touch on some important points around the fact that most people who try will quit, but when we're looking at the different evidence base, it's really important to think about certain types of support that can really boost success. So this is data from randomized controlled trials. And what it's essentially showing is that when people make a quit attempt, there's a very steep drop off in them staying abstinent in the first few weeks. By about a year, around a little less than 10% of people that used no support, so used placebo in these trials, were still abstinent, compared with varenicline, which had around 23% of people who were still not smoking. So again, around 1 in 4 people still abstinent may not seem like the best outcome, but actually you're doubling quit success. And if you're thinking about a large population of people, that's a really good gain. And it can have a really big impact on improving public health. Next slide. So from our data, we can see that about 1 in 3 people who smoke tried to quit in the past year. And then of those people who tried to quit, approximately 1 in 4 are still not smoking. And this might seem quite high, but that's because when we define that measure, that includes people who made a quit attempt yesterday, perhaps, and today are still not smoking, or made a quit attempt 11 months ago and are still not smoking. So together, that estimate is around 1 in 4 people who are still not smoking. Most people try and quit without any support, which I'll touch on again, Hazel mentioned earlier, and how people try and quit really matters. Next slide. So in terms of how people are trying to quit over time, Hazel presented the most recent estimates. This is helpful trends to look at. Consistently, using no support has been the most frequently common way people have tried to quit, which is not really a cessation aid, but it's really useful here for context. E-cigarettes became much more popular in 2013 onwards, and they've been kind of competing, jostling a bit for primacy against people using no support, but generally have been the second highest aid used in quit attempts, which, considering the kind of harm misconceptions around e-cigarettes, which I'll touch on a bit later, is pretty staggering considering. And I also want to highlight the kind of historic trends in the use of prescription medications. You can see back in 2011, around 1 in 5 quit attempts, people were using prescription medication. That's dropped dramatically down to less than 10% now. And as Hazel touched on earlier, around 3 to 5% of people are using face-to-face behavioral support. So not many, but that can be increased. And it seems like there's demand for it to be increased, which is fantastic because they are effective ways to help people quit smoking. Next slide. And again, I'm kind of going over old ground here. I'm sure you're all very familiar with this, but I just wanted to really zone in on what we know are the most effective ways to quit smoking. So on the left-hand side of this figure, I've put a purple box around e-cigarettes, varenicline, evidence-based websites and digital tools, prescription NRT, and face-to-face behavioral support. Those are all, from our study and from randomized controlled trial data, shown to be the most effective ways to quit smoking. You'll notice I haven't highlighted heated tobacco products at the top. I can maybe touch on that in the discussion later. There's very good reasons why that's not included in this package, but providing people with these different tools and options to try and quit smoking is really important. Next slide. So I'm not sure how long I've got left. I think I have 2 slides left, but I just wanted first to say, considering the popularity of e-cigarettes and how effective they are, it's surprising that we see that data considering how bad the perceptions are towards the harm of e-cigarettes or vapes compared with cigarettes. This is the most recent data. They have never been worse. There is good scientific evidence that vaping is substantially less harmful than smoking, but according to our data, around 80% of people either think they are equally harmful as cigarettes or more harmful. That is absolutely awful. It could be so much better. It's quite challenging in how it's reported in the media, and some leading health organizations are quite confused about this, which I think doesn't help. But if there's a way at your local level to help communicate this kind of risk continuum, with vaping being not risk-free, but substantially less risky than smoking and effective for smoking cessation, that would be fantastic. And it's important because if you're trying to quit smoking with a vape, but you come to a belief that they are as harmful as cigarettes, then that might mean that you think you might as well just continue smoking, which would be a really bad thing. Next slide.
1 minute, Loren. Yeah.
Great. I think I'm on time. So just as a kind of fun exercise to illustrate the sort of benefits we could get at the population level by driving people to make quit attempts with stop smoking services. I made some kind of very broad assumptions, and there's some working in the slides that will be sent to you later. But essentially, if we're able to increase quit attempts from the current level of 33% to 50%, and if we're able to increase stop smoking service use from around 5%, which it is now, to around 25%, that could generate an additional 100,000 quitters each year on top of the existing number of people who are quitting. And that's obviously not a small number at the population level. If every authority can kind of contribute towards this, that can help accelerate the decline in smoking and help achieve that smoke-free prevalence around 5% in the nearer future. But I'll stop there and I'll pass on to the next speaker. Thank you.
Loren, fabulous. Thank you. That's astonishing about those perceptions of vapes rising. That really surprised me. Someone popped up a shock face emoji there that I completely agree with. Our next brilliant speaker, the director of Fresh and Balance, Ailsa Rutter, who's going to talk to us about an evidence-led approach that's being taken in the Northeast. Ailsa, over to you.
Thank you very much indeed. Next slide, please. So for those of you who aren't familiar, the North East has been really fortunate to have a comprehensive approach to tobacco control going for 21 years now. And that is truly thanks to the combined leadership across our directors of public health and our local authorities, our NHS trusts, the Integrated Care Board. And I did just want to stress this because I think it's really important at this juncture in time to really think big picture, to think as strategically as possible, and to really have in mind a very strong, clear vision for an entirely smoke-free country. We've taken an 8 key strand approach for the last 21 years, and this is very much based upon the evidence base. There isn't one magic solution, but what I wanted to really stress is by absolutely recognising that you need to have a comprehensive approach. This is partly why, well, this is really why the North East has achieved the biggest reduction in smoking rates of all English regions. Collaboration with national partners led by ASH has been really important, and I'm very proud that we've collaborated across the whole of the North consistently through lots of different changes to infrastructure, lots of different funding streams, but collaboration has really worked. Next slide, please. What I'm really pleased about as well is to think about the opportunities now that we have to really build regional programmes through that locally together approach, and, you know, really supporting the brilliant work you're all doing on the ground. So ASH is a fantastic toolkit. How do you get a regional tobacco control programme off the ground? And a huge well done, because we now have nearly the whole country once again covered by some level of coordinated programme. Next slide, please. So I was asked to really think about the 10 high impact actions, this fantastic document ASH published back in January 2022, and to bring this to life in terms of some of the things that you can now be thinking. And I'm going to rattle through this, but these 10 high impact actions have stood the test of time. Next slide, please. So the first one, Hazel's really covered already, about we really need to keep reinforcing smoking's the key thing that you focus upon to tackle health inequalities, and the important role to work in partnership. So what I'd really like to flag to everybody today is, if we think about the really important partners, for example, for the Tobacco and Vapes Bill, the important role of your local tobacco alliances, do you have a really good working relationship with trade and standards, and then also environmental health? And we're really fortunate in the North East. We've got fantastic partnership working with OHID, with our LAs, with our NHS trusts, and we bring them together in a number of networks. And this was the wonderful local tobacco leads a couple of weeks ago. Next slide, please. This next one, really importantly, and I think, you know, picking up on Gemma and the fantastic opportunity we now have with all of this funding and the brilliant work we've got from UCL looking at the toolkit and what this is telling us, We really believe that we need to think not really stop smoking services, but let's think about this as stop smoking support. Let's think about all of these things coming together in terms of a stop smoking support system. And what's really struck us here in the North East is when Joanna Feeney, our stop smoking systems manager, did some mapping last summer around stop smoking interventions that are in place across the localities, whether it's local authorities who have commissioned different things or it's through our tobacco dependency treatment services. There is so much more actually happening out there than perhaps sometimes we've thought through that traditional kind of stop smoking service model. There are huge opportunities to expand kind of the normalization of just giving quitting a go. It will require whole action system. And I think what's very important for us to recognize is the way that we need to motivate smokers to quit is through the media and communications, the normalizing quitting, and people to really think they identify with this. So I'm going to bring this to life a little bit more next. Thank you. What we really believe is we need to put the smoker at the heart, the person who smokes, their needs, and give them as many different options to quit smoking as possible. We firmly believe that this isn't about kind of anybody pinching each other's smokers or getting obsessed with who counts the quits. We really want to think that this is about giving people a choice on how to quit, giving them access to support anywhere, and really thinking about harnessing as many different approaches to this as possible. We actively use the UCL Smoking in England toolkit. We are looking at that data, and we can see what we're doing in terms of we just need to increase quit attempts overall. We absolutely want people coming through the best quality support as possible. But we are now in our region planning to get down to zero smoking across all groups. Next slide, please. And I think it's very important to recognise the difference between population level interventions, and they increase overall quit attempts, they expand reach, but also individual level interventions. And I think, I used to work in a service, set it up 26 years ago, very different world now. And we really do now at individual level need to make sure that we've got really bespoke, high quality support for particular priority groups. Next slide, please. And in terms of harm reduction, it's very, very important that we have leadership on this, brilliant leadership in the region from our ADPH North East, very clear position statement on nicotine vaping, which is matched in parallel by a very clear, consistent position statement from our ICB in terms of the role that nicotine vaping can play. And it's very important, I think, that we all have clear, consistent messages, and we have those through our regional quitting hub on Fresh Quit. Please do look at this. We've got a comms guide, etc. Next slide, please. What's also really important, high impact action 5, is to communicate the harms and the hope. We've got significant experience in the North East through lots of insight we've done over many years and things. And we absolutely believe that the role we've played around communications, and there is brilliant comms work happening across the country now, and has been for many years, but this is really important to really help trigger that behaviour change, to frame the harm, a range of different reasons why giving quitting a go. 2026, a fantastic opportunity with the bill coming in. And we also, believe it's not just about when you're on air and when you've got like a 4-week burst, but it's all year round. It's building this social movement. It's the social media approach. And again, being really clear where we're driving people to find more information. Next slide, please. And real stories are powerful. So, you may not have loads of budget in your locality. You may not be fortunate, like in the North East, where we've got dedicated funding from our LAs and from the NHS, including also some additional funding through top slicing, some of the new additional funding. You may not have that, but there is lots of things that you can be doing. Real stories, very powerful, showing real people who have quit, who have suffered from smoking related harm. Also for us, the fantastic advisors, the fantastic tobacco dependence treatment people, to really show that people like you could go to these services for support, etc. But we just really want to have a very clear message. Give quitting a go. You're not too old. It's never too late. And to not feel like a failure. And there is very great opportunity to pool your budgets, to really think about a consistency of message, increase your effectiveness, etc. Next slide, please. So real people, real faces, faces of the services, faces of people who have used them, etc. But also people who have quit, by their own channels and not necessarily gone to a service. So lots of examples there. Next slide, please. So another high impact action is tackling illicit tobacco. This is likely to become more of a thing because of probably tobacco industry hyping it up as a result of the bill. I'll just flag to you that we've got lots of freely available information, resources, PR, guided strategic framework on our Fresh website. We do think that this should be a key focus in your local alliance as well. Next slide, thanks. And promoting smoke-free environments. Let's not forget that the key place where the harm is actually breathing secondhand smoke in the home. So we also have consistently taken a strategic approach around this, and we do think there's a great opportunity to still look at this, not presume it's all been sorted in that space, and there's lots of opportunities here for our NHS, brilliant partners as well in terms of paediatrics, etc. Again, we've got freely available things on our website. Next slide, thank you. And then high impact action, interesting one, enabling young people to live smoke free. So what I wanted to just emphasize is youth smoking has dropped because we haven't directly targeted youth. We haven't been doing the things the industry wanted you to do, which is to go into schools. What we've done instead is change the adult world. We've supported adults and carers to quit, protection from secondhand smoke, get rid of some of, have very effective regulation over these years. So just be really mindful what the tobacco industry want you to do and think about that, because it's not always necessarily evidence-based. Next slide, please. And set targets. So use the toolkit. It's brilliant. There's also fantastic new Stop Smoking Service Data Explorer from OHID. We're looking at that as well. But I did just want to emphasize, it's very hard to see, but you can now see what's happening across the regions. And I'm really delighted. The North East has seen the highest overall quit attempts, trying to quit smoking, and all of these things really coming together as a system is what's going to drive us down. And we've got a very clear declaration. Let's move beyond 5 by 2030. We're saying we're going to have a totally smoke-free future. For us in the North East, we're aiming for zero tobacco smoking by 2040. Next slide, please. And that vision is shared by everyone. Last but not least, there's a high impact action to protect from tobacco control policy. Know the public support this. Have your clear vision. Cross-party support. Here is a reform councillor with the Labour local MP united on this. And my last slide was just the contacts for all of the people that are in the regions that are there to support you. So a huge thanks very much. Thank you.
Brilliant. Thank you very much, Ailsa. Lovely. So much in there. Such richness and opportunity. And we've got more coming because we're going to look at another regional programme, completely different, opposite end of the country. We're moving from north east to southwest, and the Director of Public Health at North Somerset Council is Lenny. Matt, over to you.
Thank you very much, and very relevant to be following Ailsa and to hear about the amazing work in the northeast, because that's very much the sort of approach we're looking to try and build in the southwest and build on some of our strengths. I guess in the southwest, quite often we're thought of as one of the healthiest parts of the country, but we do have significant health inequalities in the southwest. It's not all bucket and spade living, and we are desperately determined to try and do something about that, and working together as a region is a really important way of doing that. So we go to the next slide, please. So this is about using the changes in the funding as an opportunity for us to actually commit ourselves to a different way of working. Ailsa was talking about additional grant being top sliced for regional working. Well, this was our opportunity to go back to top slicing some money, and across the DPH network, we've all been working on smoke-free outcomes for a long time, and this was a chance to reset and make that commitment to a partnership working. We're very much focused around trying to help us meet those targets and to create the kind of long-term movement stuff that Ailsa was talking about there. So we want all those interventions to be available in as many places as possible. But the focus that we had with this additional money was about trying to use more of a behavioural science and communications approach. So something that could add value to each of our local systems and to really push forward with those ambitions. And we've moved from the idea, which first was floated maybe about a year and a half ago, through into now actually having someone who is our lead in this area, Benji, who used to work at the Behavioural Science Unit, and he started with us in October last year, initially on a 2-year basis, but we're evaluating clearly to try and show the impact to see if we can hardwire that into our system. And we're lucky to host that within our council here in North Somerset. Go to the next slide, please. So why did we do this? Well, I mean, it's building on the obvious, really, isn't it, in terms of the impact of smoking on our population's health and well-being and the huge inequalities that exist. But we did have something regional. Smoke-Free Southwest, I was involved in some of that work back in the day when I worked at regional level. That was set up by our former regional director of public health, Gabriel Scally. But when we had the budget cuts in public health in the sort of mid 2010s, that work retreated, and we were always, proud of and jealous of the work that continued in other regions. You can see what Fresh have done, Greater Manchester and other regional collaborations exist. But the new funding helped us think differently, and let's try and do some things at scale where we can. And also we have the advantage of there's a really strong culture of collaboration across the Southwest public health teams. We've got some outstanding people working on smoking cessation, on wider tobacco control through our public health teams, through the tobacco alliances. People are keen to collaborate and try and make a bigger impact as much as they can. And so what we did was take a sort of contribution based on population size and that kind of trust and acceptance that there's more that unites us than is different, and the ability to think strategically about key population groups, about key opportunities to impact, was the thing that we really needed to do. So, we wanted to try and use the opportunity of the new funding to go further and faster with the outcomes that we know are so important for our population. If we go to the next slide, please. So in essence, this is where we're at. So after Benji coming in, he's done a great piece of work. He's been out talking to our alliances. We've been speaking as a group of directors of public health. And these are the 6 areas that we're going to concentrate our next couple of years on. So one is that point about regional insights. So this is about making sure that we're constantly understanding what's going on in our population. Loren presented some fantastic research there about what's going on, and having the data and having that insight and continuously playing that not just into the way we do our services, but also the way we can bring stakeholders with us in that change is really important. The comms and campaigns, so we're looking to scale up and to have that, again, back to that point about when you don't talk to the population regularly about the harms of smoking, you can see some strange things happening in people's perceptions. So we need to be able to do that at a whole population level and also at certain cohorts, so that we can really get the right support in around people, make it look acceptable, make it look interesting for people to engage with the support that's on offer. We're building capacity around behavioural science. So we have a good network already that exists across the Southwest, which I'm lucky enough to chair, but we're trying to build that into all of the work we're doing around our smoke-free outcomes, knowing that that can really help services hone in on the things that are going to matter most to local populations, and where we can do that thinking at a whole system level across region. Scaling up a best practice, obvious to say, but important to have a sort of systematic way of doing that, making sure that as a collective we are learning from the best and applying that learning as quickly as possible, and being open to doing things differently if the evidence takes us to new places. Digital is a big part as well, of course, about how we connect with people, about how we give people confidence in using our services, and we've got lots of examples of different approaches across our region, and we will always learn nationally as well. What are the things that we can do that really help people to have a good initial contact and to use the tools and resources that are available? And then finally, the last box is a bit about, and there's much broader work here, as it will be across the whole country, about connecting into service opportunities that already exist. So we've got a particular piece of work around lung cancer screening and being systematic about how we can make sure we're getting good referrals into the right interventions and trying to bring people towards a quit attempt as quickly as possible and making that a successful quit attempt. So we have our primary outcome is about the increase in quit dates and the conversion into successful quits. And that's what we're focused on in terms of all of our activity, but we know we're doing that as a part of a wider environment of tobacco control and all of the things that impact on the opportunities for people to step forward and be supported successfully. So we go to the next slide, please. So this is just about sort of reflection back out in terms of we could have done all these things on our own, but we clearly didn't. So we are looking for that greater reach. The Southwest is very connected in lots of ways, you know, naturally in terms of its geography. The peninsula goes down in a certain direction. So our communications and our sort of cultural links are quite common. So we want to be able to say things and do things in such a way that makes sense to people, regardless of what geographic boundary you go over. Economies. Okay, thank you. Almost there. Economies of scales is really important. So if we're talking about effective interventions, what can we do at greater scale? Lower cost per quit. Does it release more resources into other activities we can do to help people? Duplication is something we're all trying to avoid. And I think this is true not just within the Southwest, but nationally. Sharing resources and being generous in how we do that is really helpful. And then it's that culture of continuous improvement. And certainly as a group of Directors of Public Health, we're really keen to sponsor that. We do a lot of work in that space. And so pushing further forward with this, and I think this is probably just the start of what we can do as a region to really push home on all of our ambitions around a smoke-free future for the Southwest. So yeah, I'm going to stop there, hopefully just ahead of time.
Perfect. Thank you, Matt. I love a plan on a page. Brilliant. From the Southwest, our final speaker is up in the Northwest. We're going up to Knowsley and Dr. Sarah McNulty, who's the Assistant Exec Director of Public Health. Sarah.
Thank you. Yeah, we're zooming around, aren't we? Yeah, I'm Sarah McNulty, DPH at Knowsley Council, but I'm also the lead director for our programme, which is altogether smoke-free across Cheshire and Mersey. So I'm just going to share our approach, and it will just build on what we've heard already, and how we're building a whole system approach. Can we just have the next slide? Thanks. So a bit of context setting. So for more than 20 years, the 9 directors of public health across Cheshire and Merseyside have worked together through a joint board, pooling expertise and pooling resources through CHAMPS, our public health collaborative. We run shared programmes, shared campaigns and innovation at scale. And we're supported by a small but wonderful programme and communications team. Since 2023, the ICB, Director of Population Health, has become the 10th member of our board. And that means that our tobacco work is jointly owned by the local authorities and the NHS, which gives us a really strong platform for system change. Next slide, thanks. So I won't dwell on this, but we have a huge challenge in Cheshire and Merseyside. Some of our local authorities are among the most deprived areas across the country. Life expectancy and healthy life expectancy are below the average for England. Certainly in my locality, healthy life expectancy seems to be going in the wrong direction, which is of concern. We've got the 3rd highest COPD prevalence in England, and actually that's within the context of high levels of childhood poverty and other indicators of deprivation. So lots to do, huge challenge. Next slide, thanks. So our Altogether Smoke-Free programme is part of a wider programme of work to address inequalities that we've been developing for the last, it says 2019 on that slide, so the last 6-7 years. Altogether Fairer is Professor Michael Marmot's and his Institute of Health Equity work. They were commissioned to do a very large report and make recommendations for all system actions to address health inequalities, and the ICB, the NHS has signed up to this, and all the local authorities have signed up to this. So we all work collectively to implement those recommendations, and it means that we're able to situate our Altogether Smoke-Free. You see where the names align. We're allowed to pick. we pitch that within the setting of the wider altogether fairer work. So it just adds value. Next slide, please. So a smoke-free Cheshire and Merseyside, this slide just describes our approach and our strategy for driving down smoking levels and addressing inequalities. So our smoke-free strategy and framework was launched in 2024. It's collaboratively funded, so we pool resources, and I think Matt's just described some of that. So we pool our resources from our local authorities, but also from our ICB as well. And it's designed as a system-owned multi-component programme rather than a single project or campaign, which means that partners across the system have a stake in its delivery and its sustainability. So we're not just in this for a one-off campaign, we're in this for the longer term. And at the moment, we're also looking forward to how that might look in the future as well. So we've put in a lot of effort to build the foundations of a regional tobacco control system, rather than just delivering individual initiatives. And we've got shared leadership and strategy across, like I say, those local authorities and across the NHS, as well as our other partners. So we also work with ASH, of course, your key stakeholders, and provide a lot of support for us, but also our VCMSE sector, our enforcement agencies as well. One of the key things that we've done is been able to bring together our commissioners and really nurture how they work together and how they can innovate together as well. And we focused on mobilising that wider workforce as well through training and very brief advice, and the Smoking Ends Here, which is our website training hub, and supporting professionals to prompt quit attempts. Sorry. We've also done a lot of advocacy work as the bill has been passing through Parliament, and we've been able to get quite a lot of media focus on that, which I think has been very useful. We've also managed to get a lot of media focus on our campaigns too, so we're able to amplify. Next slide. I realise I'm really rushing through this. So now the foundations are in place, that we really need to focus even more on activating the system to, as we've said, increase those quit attempts, and really reinforce successful quitting and adding value to the work that our local services and commissioners are doing. So we delivered a large-scale behaviour change campaign across Cheshire and Merseyside, and like others, using real people, real stories, and from people affected by smoking to motivate those quitters. So we recently had a What Will You Miss campaign, which got really good traction. We've done a lot of insights in order to develop our next campaigns, which will have a general reach, but also some more targeted focus on particular target groups. But again, you know, the absolute wealth of insight that we've got is informing that. We've put a really strong emphasis on reducing inequalities with outreach and communications. So some of those cohorts that we're focusing on are our routine and manual workers and communities with higher smoking prevalence. So we've identified them as being targets. So our website, which is our Smoking Ends Here brand, and the website provides a single front door for information, for support, and also to direct people to their local services. And we've had over 100,000 unique website visits so far, so that's really, really positive. And even more positive, we've just seen the quit data for the first quarter of 24-25, which absolutely aligns with the launch of that website. And actually we've seen in the Northwest, the six top performing stop smoking services are in Cheshire and Merseyside. So I'm really starting to see that work translating into quits. Next slide, I think. Okay. So challenges, like many areas, we're all facing challenges. Lots of stakeholders from a variety of agencies. It can be difficult to ensure that all voices are heard there. We do have strong governance in place. We do have a dedicated stakeholder engagement strategy to try and help that. It's not easy navigating some of this through NHS reform, and that does give us some challenges. It's quite a stressed place, the NHS, certainly locally at the moment, but we do have a lot of commitment, and we do flex, and we're able to flex and amend, and we do find that we still do have that commitment and passion from people, and we really rely on that as well. And there's some variation across the patch. So local authority stop smoking services work differently. They work, and some of that is absolutely necessary. You know, we all have slightly different communities, but we also do have a lot of similarities, and we're currently working on a system review to determine our current potential offers and how best we might promote these and make sure that they all flow together. I think that's me, and I've got a minute left. Yeah, there you go. So in summary, I guess, just to say that our stop smoking programme is within a broader programme addressing health inequalities, and we have buy-in from our local authorities and also our regional NHS colleagues, and we work together as a coordinated system rather than providing isolated interventions, and that pooling of our resources enables us to do some of that bigger picture stuff, such as campaigns, such as insights, such as looking at the flows across the system. That's probably me. Thank you.
Sarah, that's brilliant. Thank you so much. And thank you to all our speakers. From a chair's point of view, thank you for sticking to time. But in terms of everyone on the call, fascinating, what brilliant depth, insight, challenge to send us all out there and continue doing our work. Look, there've been huge amount of questions in the chat. Ash, quite brilliantly, are going to trawl through all of the chat and make sure that every question is answered, and then they will email out those answers individually. So your chat question will be answered. But we have got time now, very quickly, because we've still got all our speakers with us, just to take a couple of questions now, if there's something anyone wants asking. I'll try and specify who you want to ask. I do really quickly. Sarah, could you quickly tell us a little bit more about What Will You Miss?
Yeah, so What Will You Miss was a campaign that we run kind of over the New Year, the Christmas and New Year period. And it was really focusing on real life experiences and really trying to emphasize the positives of giving up smoking, you know, being able to, you know, walk your daughter down the aisle, being able to play with your grandchildren, things like that. So really trying to pull out the positives. And we managed to, well, he didn't take that much persuading, to be honest. We had a lovely service user who was an absolute advocate for local stop smoking services and really promoted just the benefits of stop smoking.
Brilliant, thank you. I haven't got any hands yet, so I'm going to pull one question out of the...
I don't think that people can. We don't have it set so that people will be able to unmute themselves. So I know I can see Wendy's put her hand up, but I'm not sure she'll be able to talk.
I
can post. I've done a summary of the key questions, so I'll just post them in the chat for you now, Chris, so you can just pick those out easily. Okay,
cool. Someone in chat had mentioned, and this is quickly one for you, Hazel. Someone had pointed out the connection between smoking and alcohol, and all of us with our broader public hats on, and looking at the amazing work that we're doing on tobacco and smoking and nicotine, it feels like maybe we want to start grasping the next nettle, and is the next nettle alcohol?
Well, I mean, Ailsa is really the one to comment on this, because she also has the regional office for alcohol as well. But Ash does host a collaboration with the Alcohol Health Alliance and the Obesity Health Alliance, looking at these 3 big killers. And I think you're very right in saying if we can reduce the level of drinking in society, it is likely to benefit smoking as well, because we know that drinking is associated with relapse, etc. So there's definitely synergies, and plainly alcohol is also a very big harm to society. Ailsa, would you want to?
Yeah, absolutely. And I put a comment in the chat as well, Chris. I think the number one thing I would urge everybody to do here is to advocate that what we need on alcohol is a national alcohol strategy. There hasn't been one since 2012. And if we think about the success we've made in smoking, it has been because of that bottom swell up to advocate. And then we've ended up with political will, and we've ended up with regulation. We're in a very different space for alcohol, but it is becoming increasingly urgent. We've got a blueprint from Balance. It's on our website. They're our key policy asks. And like Ash leads the Smoke Free Action Coalition, there is the Alcohol Health Alliance, and we're working very closely together. But I think we must push for political action on alcohol too. Thank you.
Yeah, I absolutely agree with you there. I'm going to take some questions from chat. Now, I saw this. So now we've got these broader ring fence budgets. How this, I think, this is for Ailsa and Matt and Sarah. How are you going to think about your top slicing regionally now that the SFG isn't a standalone budget? How are you going to do the math to get to the 3%? I think is the question.
So do you want me to
go on?
Do you want me to take that?
Yes, if you think you've got an idea.
Well, I think the brilliant leadership of the directors of public health in the North East has been really crucial, actually, for them to recognise like the evidence-based approach and things. So what we can show is we're working really well as a system. We've and it is about like actually overall triggering quits. And I think it is my point about we need to redefine what we mean by stop smoking services. And I think the more we can think about this as support and as a system, in the North East, we get funding from all 12 local authorities at 27 pence. That's irrespective of the Stop Smoking Service grant. We've had that for a long time. The ICB also matches that. But then in addition, they put 12% in for some regional programs. So, I think it is really worth us all sharing kind of how that's happened, and some of the business cases and things are on the ASH website as well.
Brilliant, thank you.
Do you want me to add to that, Chris? Is that
yes?
helpful?
If you've clearly already done some thinking about it, so go for it, Matt.
Yeah, well, I just think it's common sense, isn't it? We continue with what we're doing and we add on to, not take away. So I think the bit now for me is what Ailsa's talked about there is the more leveraging more NHS funding into this space is one of my key ambitions for the Southwest. I was at an ICB board meeting talking about this yesterday, about we have infrastructure. We should be thinking as a whole system in terms of how we fund this and support this work, because it is the best way for us to deliver on the outcomes that we're all saying we're talking about, whether it's a whole system strategy level or neighbourhood level or whatever it is. These are the ways in which we can deliver significant improvements in the population's health. So it's a win-win for everybody, but it does require everybody to then tip into that way of working and not think about it by single organisation. I think that's the key.
Brilliant, thank you.
To add?
Yes, and then I'll make this the final comment because
okay.
I do want to finish it on time.
Yeah,
Thank
I mean, we actually had agreed before the ring fence within the ring fence within the ring fence within the ring fence came in. So we've got that long-term agreement for 3 years, and the ICB agreed to put in money as well. And it is just a sign of just the commitment that we have locally.
Brilliant, thank you. As all of you have said in various different ways, absolute key to all this is working in partnership and working with those other organisations, working with each other, using all the but there's been so much brilliant pointing towards the resources that are out there today. It's absolutely fantastic. So look, you will get all the slides, you'll get the individual answers to the questions will come out to you all. Huge thanks to all our speakers today. I've found this is just brilliant. It's lovely. It's lovely to have hope and know that you've got resource and that you can get out there and do something. So thanks everyone for all the hard work you're doing on it. And I wanted to finish with the title of one of Hazel's slides and leave us all going out into a happy Friday because a smoke-free country is within reach. Thank you, everybody. Goodbye.